Everybody. It's my pleasure to introduce this morning Dr. Michael Johns. Michael received his Bachelor of Science degree in Chemical Engineering from Lehigh University. That was followed by his Master's of Engineering in Biomedical Engineering from Stevens Institute of Technology, and then his Osteopathic Medicine degree from the Philadelphia College of Osteopathic Medicine. Mike, during his tenure here at Christiana, has produced three peer-reviewed manuscripts in high-profile journals and also 13 posters and oral presentations at various society meetings. And I'm sure that helped Michael in matching at Brown University's programs for his colorectal fellowship, which he will start next year. Dr. Johns' topic this morning is the microbiome, what it is and its potential role in surgical complications and potentially even in preventing them. So, Michael, I'll turn it over to you.
Excellent. Good morning. Thank you very much, Dr. Petrelli, for the introduction and the assistance with this presentation, and welcome everyone to my grand rounds. Pictured here is Joseph Lister, who saved us from the horrors of pre-antiseptic surgery, and he serves as an inspiration for this talk to me. Over the past 2 decades, there's been a lot of interest in the microorganisms that live in an association with the human body, collectively known as the microbiome. The microbiome is made up of eukaryotes, bacteria, viruses, and fungi that live on and in each of us. And a lot of interest looks to identify connections to certain disease states, complications, and more. Bacteria on average outnumber the human cells in our own body by about 10 times. Some of these bacteria are helpful, producing essential vitamins and minerals. Some teach our immune systems how to recognize dangerous pathogens. Some produce anti-inflammatory compounds. Within the recent past, there have been numerous studies demonstrating that compositional changes in our microbiome can correlate with disease states. This raises the possibility that manipulation of these communities could be used to help treat and/or prevent specific diseases and conditions. Today, we'll be discussing the microbiome, and sometimes referred to as the forgotten organ, and how it impacts us, the surgeons. You've probably seen the news articles. The microbiome in the recent years has been a hot topic. It's been researched in many fields: oncology, infectious disease, inflammation, obesity, even trauma surgery. Articles have shown associations to IBD, FAP, colorectal cancer, intra-abdominal adhesions, high output ileostomy, C. diff infections, autism, and many, many more. Simply searching for the gut microbiome in PubMed leads to about 38,000 articles, with an explosive increase in the last few years. A lot of disease states have been associated with dysbiosis. It is defined as a reduction in microbial diversity. About 2 years ago, I caught the microbiome bug. I became very interested in how what we eat affects who we are and what we ail from. I even published this article about the connection between the microbiome and colorectal cancer. Anecdotally, I think we can all agree that not all food is created equal. I often wonder, how does the food we eat, or the environment we live in, or the physiologic stressors we encounter every day change our biologic resonance, sometimes to our detriment? This morning, we have 4 main objectives. We will begin by discussing the basics of the microbiome and examine how the microbiome is analyzed. We will look into 2 common surgical problems: anastomotic leak and surgical site infections, and evaluate the research that suggests that the microbiome is at least partially responsible. Lastly, we will look into ways to use the microbiome for our benefit, to harness the microbiome for the advantage of our patients. Metagenomics is the study of genetic material of a broad, mixed community. By looking at the entire community of bacteria, fungi, and viruses, metagenomics enhances our comprehension of the diversity, ecology, evolution, and functioning of the microbial world. This metagenomic approach examines the collection of genomes derived from microbial communities sampled within their natural environments. Combining this with the development of faster sequencing techniques and computational modeling, our capacity to understand the living world has greatly increased. In 2008, the Human Microbiome Project was established by the NIH. It's an interdisciplinary effort to gain an understanding of the microbial communities at multiple sites: the nasal passages, the oral cavity, skin, GI tract, and GU tract. And it examines the role that these microbes play in human health and disease. Since that time, the Human Microbiome Project has launched their second phase, looking into the microbiome's connection to preterm birth, inflammatory bowel disease, and type 2 diabetes. How exactly does metagenomics work? There are two main methods for analysis of the microbiome: 16S rRNA gene sequencing, and the other is shotgun whole genome sequencing. To the right, you can see where each method is considered advantageous when compared with the other circled in red. 16S rRNA has high bacterial and fungal identification. The host DNA doesn't interfere with the analysis, and it is cheaper. However, shotgun sequencing allows for species and strain identification and functional profiling. The methods of analysis are quite different. The 16S rRNA gene is a component of the transcriptional machinery of all DNA-based life forms. This method uses PCR primers to target the variable regions of 16S, making it possible to amplify a gene, which are then compared to a reference database, and specific microorganisms are identified. Shotgun sequencing looks at all of the genomic DNA in a sample. This allows for more specifics regarding strains of microbes and other applications of analysis, even determining proteins that are produced and genes that are expressed. Because shotgun sequencing is a newer technology, the reference databases are less robust, but as our understanding grows, this approach will become more functional and more important. Taken together, both of these methods have huge benefit over typical culturing techniques where bacteria is grown on plates and analyzed. That's costly and that's time consuming. Many of the studies using 16S rRNA sequencing have found sequences that do not belong to any known cultured species, showing that there are numerous organisms that haven't been isolated previously, and prior methods may only find a small percentage of organisms in a sample. Now that we've covered some of the basics of the microbiome and the tools for analysis, let's begin talking about conditions specific to surgery that affect us every single day. Anastomotic leaks have plagued surgeons for many, many years. Sources state that in the colorectal literature, the mortality is between 6 and 39%. There have been numerous techniques and technologies developed to help prevent and fix anastomotic leaks. Things that come to mind are indocyanine green angiography, omental buttressing, and fibrin glues. What are the typical components that any surgical textbook would say contribute to an anastomotic leak? Blood flow, tension, radiated tissue. But what about those patients who don't have any of these risk factors but still have an anastomotic leak? What caused it? Typically, it's chalked up to technical error. It's the surgeon's fault. Today, I hope to demonstrate that the surgeon may not always be at fault, and that hopefully we can come up with a solution. The first evidence that bacteria may contribute to an anastomotic leak was in 1955 by Isidore Cohen in New Orleans. He performed a canine model where an end-to-end anastomosis was devascularized for approximately 5 centimeters. He then threaded a catheter into the bowel lumen proximally, and in the experimental group, an antibiotic solution was infused intraluminally. The results were striking. For the control group, without any infusion of antibiotics, this devascularized segment was uniformly fatal: massive peritonitis and hemorrhagic necrosis. However, in the experimental group at animal sacrifice, 5 of the 6 animals had perfectly intact anastomoses, even to the point that they couldn't be distinguished from the surrounding bowel. The first picture shows the bowel immediately after the anastomosis and devascularization. You can see the poor appearance of the bowel here. This second picture is the bowel appearance of the control animals. There is complete separation of the bowel with fecal contamination. These final pictures show the experimental animals. The anastomosis is shown externally with identical appearing bowel on both sides, and the mucosa of the normal shows normal appearance on both sides of the anastomosis as well. This study showed that despite an intentionally ischemic anastomosis, the removal of microbial content prevented leak and actually reversed ischemia. What about hypoxia? Intuitively, tissue hypoxia would make sense to cause an anastomotic leak. This was a rat model where multiple groups underwent a variety of procedures: sham surgery, segmental devascularization, distal colectomy, and devascularization plus colectomy. In order to determine the level of hypoxia, on post-op day 6, all animals were injected with a specific immunohistochemistry compound that predicts the partial pressure of oxygen at the submucosal level, and then they were sacrificed 30 minutes later. These animals underwent rigorous testing, including evaluation of anastomotic healing score, hypoxia, collagen quantification, and necrosis evaluation. The results of the hypoxia probe experiment showed that hypoxia does not differentiate healing and anastomotic leak. Simply put, as you can see here, the tissue oxygen levels were not altered 6 days after colectomy and/or devascularization, regardless of the anastomotic healing score. For completeness sake, there were no differences in apoptosis or necrosis on H&E staining between the groups as seen here. However, there was quite a difference in collagen fiber length, with shorter fibers seen in models that had anastomotic leak. I want you to remember this point as we move forward. Anastomotic leak in rats showed decreased collagen fiber length. Nearly 40 years after Dr. Cohn's canine experiment, another important study confirmed that bacteria are a major pathogenic factor for anastomotic insufficiency. In a study by Shardy et al. In 1994, a rat model was used to test anastomotic leak during gastrectomy. All rats underwent a total gastrectomy and an end-to-end esophagoduodenostomy. Approximately 20 rats were in each group, and they were either, number 1, orally inoculated with Pseudomonas, number 2, the control group, or number 3, decontaminated with oral antibiotic solution for 7 days pre-op and 10 days post-op. All the animals were sacrificed on post-op day 10, and the anastomoses were evaluated for evidence of leak and their bursting pressure. The results of the experimental group showed a significant improvement in anastomotic leak from approximately 95% in the experimental Pseudomonas group down to 6% in the antibiotic treatment group, and had a significantly higher bursting pressure as well. Now that we've suggested that some bacteria may be involved in anastomotic leaks, can we determine if any specific bacteria are commonly found? This study built on the findings from 2 slides ago by Dr. Shakshir et al., where they found decreased collagen fiber length in models that had anastomotic leak. These rats underwent a variety of procedures as seen in the picture. The rats in each group were sacrificed and then underwent laparotomy to inspect the operative field. In the first portion of this study, the tissue was opened and swabbed for microbial analysis. When combining devascularization and colectomy, there is a significantly higher anastomotic leak. The results of the microbial swab study showed that the collagen-degrading activity in the whole bacterial community was much higher in the models that showed anastomotic leak. So, bacteria with collagenase more likely to have anastomotic leak. Further analysis showed that the collagen depletion in models that had devascularization plus anastomosis. The white arrows denote the region of anastomosis, and these slides show a progressive loss of collagen on trichrome staining. And in those models with anastomotic leakage, there was a significant difference in the collagen content. In the third portion of this experiment, 2 specific strains of Enterococcus faecalis were introduced via enemas to rats undergoing a colon anastomosis. E1 was considered low collagenase producing, and E2 was high collagenase producing. These results show that E2, but not E1, caused an anastomotic leak associated with intestinal collagen depletion. The proposed mechanism is that only E2 could induce activation and cleavage of MMP9. So this suggests that certain bacterial strains in specific environments responding to different signals have enzyme degrading properties that may not be found typically. Now, remembering how wound healing process works, the collagen deposition and remodeling from type 3 collagen to type 1 collagen, it makes sense to look for bacteria that may have the ability to degrade collagen as a possible source for an anastomotic leak. Now, these animal models are good, but does any of this translate into human data? Think about our patients that undergo colectomies and rectal resections. We know that animal models don't always reflect what actually happens in humans. In this retrospective study from the University of Chicago, all patients undergoing colorectal surgery from 2014 to 2019 were collected. Those that developed a post-op infection were stratified into infections from an anastomotic leak, a Hartmann pouch stump leak, or deep infection not associated with a staple line. Microbial data was reviewed by intraoperative cultures from drains placed by an interventional radiology. A total of 184 patients had surgical site infections, and of them, 42 had culture data available. The most common cultured bacteria was Enterococcus faecalis. Overall, about 60% of patients had infections with bacteria that are known to produce collagenase. As you can see from the table, anastomotic leak specifically showed more association with an organism with collagenase activity as compared with stump leak or deep infection. So this leads me to ask, what truly causes an anastomotic leak? Dr. Cohn in 1955 showed that despite an intentionally ischemic anastomosis, an anastomotic leak could be prevented with an antibiotic solution. Shakespeare showed that, contrary to popular belief, hypoxia, nor apoptosis, nor necrosis may be factors, and suggested that collagen degradation levels may contribute. Shardy suggested that giving rats Pseudomonas through oral gavage led to significantly more anastomotic leaks after total gastrectomy. Shogun evaluated the certain bacteria in rat models and found that collagenase-producing bacteria were more prevalent in anastomotic leaks. And finally, Anderson showed in a retrospective human study that about 75% of patients with clinically relevant anastomotic leaks were found to have bacteria with collagenase activity. Have we considered what our patient's typical bacterial makeup looks like before surgery? What about when they receive an antibiotic bowel prep? What is their general health and eating habits? And could that explain the health of their forgotten organ that may have disastrous consequences after a major operation? How much blame should the surgeons face for something that may be out of their control? I want you to think about these questions as we transition to the next section, where we're going to talk about surgical site infections. A few years ago, this book was published. I read it during intern year, and I was struck by the beautifully analytical way that Joseph Lister transformed the world of asepsis. He devoted his life to understanding the causes and the nature of postoperative infections, and he found a solution for them. He was knighted for taking care of Queen Victoria of Scotland in 1871. He had a long correspondence with Louis Pasteur, and he was truly a visionary surgeon who understood the importance of bacteria in the world and how it affected all living things on the planet. Whether we realize it or not, we should all be grateful to his scientific method and experimentation. I highly recommend this book if you've not read it yet. Per the CDC, surgical site infections are the most costly healthcare-associated infection, with an estimated annual cost of $3.5 to $10 billion each year. Of the greater than 15 million operative procedures performed in inpatient settings, the estimated rate of surgical site infections is about 2 to 5%. The American College of Surgeons frequently publishes guidelines around surgical site infections. recommendations for practice and perioperative adjuncts to reduce infections. Most recently, it was updated in 2017, and here are some of the factors that are commonly discussed. There is no doubt that we've come a long way from the era of Joseph Lister in terms of major advances in medicine. But with all of these improvements and all of our understanding, why have we never seen 0% surgical infection rates? The current thinking is that surgical site infections are caused by direct intraoperative contamination. If an orthopedic surgeon operates on two patients with similar risk factors in the same operating room and one ends up with a surgical site infection, it's often chalked up to something that happened during the operation. This has led to a huge industry. HEPA filters, spacesuits, laminar flow ORs, wound lavage, postoperative antibiotics. All of these methods are to help reduce infections. But does any of that work? In a study from 2011 by Hooper et al., they compiled a 10-year registry of total hip replacements and total knee replacements in New Zealand. They analyzed the equipment used during these cases and evaluated the incidence of surgical site infections. In approximately 35% of cases, laminar flow ORs were used, and spacesuits were used in approximately 25%. Overall, there was a significant increase in early infections in procedures where a spacesuit was used, and also higher rates of early infection in laminar flow ORs. Also, combining spacesuits and laminar flow ORs also led to higher rates than procedures without both additions. What about in operations where wounds are swabbed, they're cultured, and they're monitored for surgical site infections? Does the bacteria growth at the surgical site actually match what grows on the cultured medium? Here are two important studies that may question what you would think would be common sense. In 1991, Garibaldi et al. Performed a prospective intraoperative culture of the subcutaneous fat in about 1,800 patients who underwent skin incisions greater than 6 centimeters. The patients were followed for excellent wound care monitoring, and infections were diagnosed by pus, purulence, or attending discretion. The demographics, operations, ASA class, and wound class are all seen here on the left. The results of their study is shown in red. There were 120 post-op wound infections. Of the prospectively collected cultures, 276 were positive. However, only 38 of the 276 patients actually developed wound infections. Furthermore, only 29 of the 38 had pathogenic bacteria, and only 12 of those 29 had the same organism. The positive predictive value of an intraoperative wound culture leading to infection was very low, about 32%, with a high rate of false positive, and concordance between the wound culture and the infected wounds was only about 40%. Similarly, in 2005, Fay-Sion et al. Performed a prospective study of 100 elective colon resections with primary anastomosis, again, where the skin and subcutaneous tissue were swabbed after fascial closure. The wounds were followed for 4 weeks, and infection criteria were similar to the other study. Of the 100 swabs that were taken, 52 yielded no growth on culture. Of the remaining 48 swabs, only 10 had clinically relevant wound infections. 7 of these 10 had an additional culture taken, and in only 4 of those 7 was there growth of a corresponding bacterium. So the takeaway is that 10 out of 48 positive cultures actually led to an actual SSI, which is about 20%, and only 57% of those had concordance with the same organism. So if there's poor concordance between actual wound cultures and the bacteria that eventually may grow at the surgical site, then where did they come from? About 10 years ago, there was a theory proposed by Thwaites and Gant that neutrophils may act as a Trojan horse for Staph aureus. Staph aureus is normally an extracellular pathogen, but recently there is evidence that Staph aureus can survive in certain cells. Some experiments show that Staph aureus can persist in the vacuoles of macrophages, and in animal models, inhibition of neutrophil migration leads to decreased bacterial dissemination. It's interesting that many of the antibiotics that we use to treat a persistent Staph aureus bacteremia have high intracellular activity, like rifampicin, doxycycline, and linezolid. Expanding on the Trojan horse theory, Krasilek et al. Performed a multi-step mouse model for experimentation. The first stage was set up to show whether direct wound contamination with MRSA would be enough to cause dermonecrosis of a wound. The mice underwent multiple procedures with various degrees of rectus injury as seen in the picture. Before wound closure, a solution of MRSA was applied to the wound for 10 seconds and then washed with normal saline. The skin was closed and each animal was euthanized on post-op day 14. When the wounds were examined, for sham surgery only, there was only small punctate abscesses but no dermonecrosis. As seen in the figures in the bottom right, as the tissue trauma increased, the dermonecrosis and abscesses increased. So this shows that despite intentional intraoperative contamination, not all mice ended up with surgical site infections. Again, these are animal models. The second stage of this experiment was developed to show whether MRSA colonization of the GI tract would lead to surgical site infections. These mice were fed a specific bioluminescent MRSA preoperatively and then underwent a partial hepatectomy. During closure, the rectus muscle underwent ischemia and injury similar to the picture on the last slide. An intraoperative culture was taken prior to closing of the incision. Additionally, two small subgroups were noted, one where MRSA was painted on the wounds and then another where the mice were given an IV dose of MRSA. Again, each animal was euthanized on post-op day 14 and the wounds were examined. The abscesses that were seen were the same bioluminescent MRSA that colonized the GI tract. There was approximately a 32.5% rate of remote surgical site infections. And in all 13 animals that showed MRSA surgical site infections had rectus muscle injury and ischemia, suggesting that injury and ischemia are required for metastatic surgical site infections. Now, this is quite interesting. Despite no manipulation of the GI tract during these procedures, 8 of the 9 cultures that were taken showed members of the bacterial intestinal flora. The mice that underwent the painting from MRSA did not show any evidence of wound infection, and none of the mice that underwent IV infusion of MRSA showed sepsis or wound infection either. This is a graphic representation of the Trojan horse hypothesis for surgical site infections. The loss of competing microbiota can lead to an invasive pathogen that will colonize an area and proliferate. Local immune cells, including neutrophils, engulf this pathogen where it can coexist. These immune cells mobilize into the circulation and they move to a tissue where immune cells are required for repair of tissue. And in these injured tissues, then have a pathogen offloaded within that wound, brought there by that immune cell that actually showed up to help, but now inadvertently colonized a wound. Certainly, these experiments show some interesting points. Surgical site infections are so common and so costly. Some methodologies used to prevent infections may actually lead to higher rates of infection. Intraoperative wound cultures show poor positive predictive values and low concordance of cultures. MRSA has some ability to remain within neutrophils, and the fact that the bioluminescent MRSA that was given orally was seen at the surgical site infections of the rectus muscle is really, really interesting to me. The surgical infections that we try so desperately to avoid may not be the fault of our surgical technique or any process breakdown that we typically blame. Certainly, the improvements since the time of Joseph Lister have saved countless lives, but lately the effort to bundle care to decrease our surgical site infections to 0 may never be achieved unless we truly recognize this evasive factor. Now that we know of two common surgical complications that have potential implications from the microbiome, are we able to use that to our advantage? In a mouse model of colorectal resection and primary anastomosis, prehabilitation of standard mouse chow when compared to a simulated Western diet led to decreased risk of anastomosis leak. The anastomotic healing score can be seen here to the right-sided figure, comparing standard diet and Western diet. To attempt a modeling of prehabilitation, some mice were shifted from a Western diet to a standard diet a few days before operation. They found that the microbiome was restored if these mice were exposed to standard chow for just 2 days before their operation, which also led to lower rates of anastomotic leak. As seen in the left lower figure, the 16S rRNA analysis revealed lower Shannon index in Western diets, which characterizes the diversity of the species. And in the right figure, the levels of collagenase-producing Enterococcus shows a sharp increase in mice that were fed Western diets after approximately post-op day 3. The age-old adage, "You are what you eat," seems more relevant than ever. This year in JAMA Surgery, a longitudinal observational study was published from the Netherlands. These researchers evaluated the association of habitual preoperative dietary fiber intakes and the risk of complications after colorectal surgery. From a physiologic standpoint, dietary fiber leads to the production of short-chain fatty acids, which colonocytes utilize as their main fuel source, and proliferation of colonocytes promotes healthy bacterial microbiome. In this study, approximately 1,400 patients were evaluated. There was an all-complication rate of 28%, a surgical complication rate of 17%, and a 5% anastomotic leak rate. From the results of their logistic regression analysis, comparing the highest third of dietary fiber with the lowest third, there was significantly lower risk of any complication or surgical complications. However, in patients who had an anastomosis, dietary fiber was not associated with occurrence of anastomotic leak. In this study, there was a low rate of anastomotic leak, which may be the explanation as to why they failed to find an association. The microbiome is a unique and ever-changing entity. The area of research has exploded in the past 2 decades, and going forward, I hope the research will continue to test theories about the involvement of the microbiome in many disease states. Today, we have reviewed 2 very common surgical complications, anastomotic leak and surgical site infections. These complications often involve guilt, shame, even hospital monetary fines. But the research needs to continue to truly understand the complex nature of these surgical complications. There are numerous other relevant aspects of surgical care that have connection to the microbiome. Post-operative ileus, bariatric surgery, onset of colorectal cancer, inflammatory bowel disease. I implore you to do some research on your own to see how this exciting field will likely change medical and surgical care in the future. I hope that we will soon be able to harness and utilize the power of the microbiome for the benefit of our patients, and that we may be able to advise our patients how to be physically and biologically fit for surgery. Going forward, I think we will need to move past the bundled care that we provide to patients. The bundles of perioperative care have led to major improvements, but if we are going to truly understand a patient's microbial makeup, we cannot rely on checkbox medicine, where everyone receives the same preoperative care, including bowel preps and antibiotics. Our patients are individual organisms with exposure to different environments and stressors. They have various levels of nutrition and disease states. It will take some of these newer microbial sequencing techniques to help us analyze each individual's microbiome and determine how to impact it before performing surgery. But I believe that in a few years, we will be personalizing the upfront treatment that patients receive before surgery. Poor nutrition is often cited in the news as leading to type 2 diabetes and heart conditions. And in the surgical literature, the loss of muscle and preoperative weight loss are considered general risk factors for complications. Personally, I would like to see nutrition, especially fiber, whole foods, and healthier foods become part of a regular discussion with patients, and I suspect that the outcomes can be impacted similar to the study from the Netherlands. Thank you very much for your attention, and I'll take any questions at this time.
Dr. Teasy has his hand up. Greg, I think you're muted.
I was just waiting. Can you hear me?
Yes, we can.
Yes.
So I thought this was a really excellent talk. Proud of your accomplishments, Mike. Now, this is an extremely difficult topic because, our ability to detect bacteria in real time and understand, its implications, the tools we use are still very blunt. So, this paints a very mixed picture because we have a lot of other evidence to support other mechanisms, right, for infection. So how does this square with one, data that shows that giving antibiotics for extended perioperative periods has been shown to be associated with higher rates of infections in certain circumstances? Two, there have been other studies that show that local factors like in wound closure, how you close, etc., is also associated with lower rates, of infection. And there are several, and then lastly, like the colon has the highest bacterial rate, or the highest amount of bacteria. So I guess theoretically that would explain why leak rates are high in colorectal surgery. Well, what about the esophagus? The stomach. Small bowel probably has the lowest rate, yet it has a moderate amount of bacteria in it, and esophageal leak rates are quite high. It's amounts of bacteria. So all these things make it very difficult to take the studies that you're showing, which I think are very compelling and certainly paint a very complicated picture, and just attribute it to that as well. So what are your thoughts?
Thank you for your question. So I think the first part showing that, giving preoperative and postoperative antibiotics leading to actual increase in surgical site infections makes sense. What happens, as we know with C. diff, is that people become not necessarily colonized with C. diff, but we are destroying the healthy bacteria within their gut, which then allows Clostridium difficile to proliferate, which then causes kind of a running out of control infection, which is similar to what you mentioned. I do think that it is a very complicated picture, and I'm not suggesting or concluding that only bacteria has anything to do with this. But I think in your question about esophageal leaks, for instance, the one Pseudomonas study actually was for a gastrectomy and an esophageal duodenal anastomosis. And by decreasing the level of bacteria there, they actually did see a significant decrease in leak rate. So I certainly think that it is a contributing factor, and it's something that we can consider going forward. Thank you very much for your question.
Dr. Palange also has a question, Dr. Johns.
Yes, sir.
David?
Hey, Dr. Johns. Great talk, great topic. Excellent job. Just was wondering, as we talk about the microbiome and how we can affect it and leak rates and all the other different adhesions and all the things it can affect, as all the studies are showing, have you come across anything looking specifically at our ERAS protocols or the use of probiotics or symbiotics to help affect that microbiome that may help us in the future? And what you thought about it?
Thank you for your question. Yeah, so there is mixed data about probiotics. Unfortunately, the thought is that as the bacteria makes its all way down to specifically the colon, is it still in its natural form to be able to actually make an impact and colonize within the colon? There is some evidence to show that your microbiome is somewhat set up at an early age, but persistent attack with healthy foods and fiber that leads to short chain fatty acid growth, and also probiotics can potentially change your microbiome for the better. I do think this is a little bit of an unknown entity, so I think the research about things can never really be definitive, especially leading to an actual impact. Say these patients saw an improvement because they changed this about their diet, but I think there's some evidence that we're certainly looking into that I'm encouraged by.
Dr. Johns, I don't see any other hands up. I don't know if there are any questions in the conference room. Oh, Dr. Rubino has a question. Dr. Rubino?
Hey, this is Dr. Wade. Actually, I'm with Matt Rubino. We are driving over to the University of Maryland. Excellent talk, Michael. It's a very complex topic, as everyone's already commented on. I have a question about the mechanical bowel preparation when we do with oral antibiotics. In the past, we used to do that, then we stopped doing it. And now again, we are doing it because we saw that when we were not doing oral antibiotics with the bowel preparation, the incidence of SSI was going up. Have you seen any articles in which they've looked at the change or alteration of microbiome with the use of oral antibiotics? And do you know if using oral antibiotics is targeting specific bacteria which are producing more collagenase versus not? Because how would you otherwise explain the decrease in SSI with the use of oral antibiotics?
Yes, thank you for your question. Great question. So you are correct. There was the old thought that we were doing mechanical and antibiotic, and then that's shifted away as people only used mechanical bowel preps, and then it has become back into favor because, as you mentioned, the complications were going higher. There have been smaller studies regarding the use of some of a metagenomic analysis of patients who were bowel prepped, not large enough to be able to say anything definitively about that. But it is certainly a topic that I think researchers are looking into. I do think that by adding the antibiotics back to the bowel preps, we are targeting some of those more pathogenic, bacteria, especially those that have collagenase or collagen-lytic properties that can lead to some of our complications that you had mentioned.
And I think, Dr. Rubino, Matt, do you have a question? Okay.
No, that was it. It was just me
okay.
and Dr. Rubino together.
Okay, thanks, Sachin. Dr. Rango?
Mike, very good presentation. That was excellent. Extremely interesting topic. Brings us, as you said, to manage the patients very differently, and probably will take us to a point that we're going to have to make very tailored treatments to each patient individually, depending on how the microbiome acts. The last thing that I read about this was association actually with schizophrenia related to the antibiotics that you may have received as a child, pretty much before you were older than 5 years old, and how actually that will change later and then increase your risk of schizophrenia and certain bacteria, including spirochetes, that will have to have some influence on what type of mental diseases you may develop as an adult. Did you read anything related to that about the use of previous antibiotics in the relationship to the type of leaks, infections that you might develop later in life, or with any of these? I know that this is actually a significant stretch of all of these, and we might not be able to do that, or anybody may have done a study related to that. But I'm curious if you actually read something about that.
Yes, thank you for your question. I mean, I think that that would be a hard study to show. I mean, to certainly try to remember back to someone's childhood to say whether they received antibiotics and what age and how many times, ear infections or sore throats or things like that. But I certainly do think that, we do know that any level of antibiotics given does change your microbiome within your colon. It typically restores, but what is left behind are some of the more pathogenic bacteria, as evidenced by C. diff infections, for instance. As you mentioned with schizophrenia, for instance, there are so many articles out there, and certainly they're not causation articles. They're just correlation, and people are looking into it. But I certainly believe that it is an important aspect of overall health and well-being that we should be considering, and judicious use of antibiotics to maintain people's biosis is very important.
I think we have one more question with Dr. Rao. Dr. Rao, you're muted.
Can you hear me now?
Yes.
Yes, sir.
Just in your research and preparation for your talk, I'm sure there must have been a lot of work done with reference to Crohn's, ulcerative colitis. And the study in those patients may offer a unique insights compared to other studies because they have a combination of medications and deranged lining of the bowel. What are the things we learned in studying those patients and leading to a change in the diet that can change the natural history of inflammatory bowel disease?
Yes, thank you for your question. I mean, there's certainly, as I mentioned, the Human Microbiome Project is this interdisciplinary, multidisciplinary team of multiple, university-affiliated programs around the country that have been looking into it. Their second stage has been doing a lot of research regarding IBD specifically. And I think you're right. I mean, we see certainly that you see higher rates of small bowel adenocarcinoma in patients who have Crohn's disease, right? That is related to the inflammation that persists and potentially the bacteria that continue to lead to inflammation in that region. I mean, I think that there is a lot of unknowns here, but I think that going forward, we're going to continue to do research in this, and it will be helpful.
Dr. Jankowski?
Thank you, Dr. Johns. Excellent presentation. From a quality and patient safety standpoint, from your readings, are there any practical changes to our current practice that you would suggest that we could potentially implement to impact our outcomes? Are there any day-to-day things that we can change or should change in how we manage these patients to perhaps prevent these leaks and other complications?
Well, I think that it's not to the point right now where I can say we can make this change and see an outcome difference. What I would consider in this case is a discussion preoperatively, for instance, during our POETS evaluations or even our in-office evaluations about patients' overall health and well-being, including their dietary habits. A lot of emphasis, as I mentioned before, has been on protein levels. We look at albumin and pre-albumin to look at patients' nutritional status. But truthfully, I don't know that we look enough at what patients are eating and if that's on the appropriate spectrum or a good spectrum, especially getting ready for a major surgical stress like any sort of operation.
Okay, I don't see any other questions from the group. So I'd like to thank Dr. Johns for excellent presentation and preparation of this talk, and thank everyone for coming. So I don't think, Ruth Ann, we have M&M this morning. Is that right?
We do. One case at 8 o'clock.
Okay. All right. Otherwise, stay on board. Thank you, Dr. Johns, and thank you, everybody.
Thank you very much.
I believe you need to sign into a different Teams meeting for M&M.